Okay, now we're recording. Sure. So the learning objectives are on the previous slide if you just joined the recording. Okay, but HIV HIV-1 and HIV-2 are a result of spillover of retroviruses that existed in primates into humans. This happened in Africa sometime during the first half of the 20th century. HIV is a retrovirus with a high genetic diversity. There are a lot of phylogenetic subtypes. There are multiple spillover events that appeared to occur from primates to humans. Most HIV infections that we see outside of Africa are group M of various subtypes. Those subtypes are A, B, and C, and so on. B is very prevalent, for example, in the United States and parts of Europe, but you also see other subtypes of HIV infections. The clinical course of infection of all of these group M HIV-1 infections, just we call them all HIV-1, are similar, although there can be differences sometimes in patients as well as differences in Africa. The differences are more stark. Okay, so HIV is a global pandemic. There are estimated to 39 million people living with HIV in 2023, of which now, remarkably, 71% are estimated to be on antiretroviral drugs or antiretroviral therapy, ART, ARV, as it's called, with the viral load suppressed. So the antiretroviral drugs are effective in suppressing the chronic HIV infection. It's an infection that lasts for life. There's viremia for life. But with 71% on HIV, these people have a prospect of survival long-term, living a generally regular life, and not passing the virus on to other people, becoming non-transmissible also. So children living with HIV, we have 1.5 million, of which it's estimated just under 50% are the viral load is suppressed by ART. There have been an estimated of 36 to 40 million deaths from HIV/AIDS and HIV-related complications since the 1980s, since the pandemic began. And particularly in Ukraine, and I put in an extra slide for that there. In Ukraine, we have a prevalence, according to the 2023 WHO and UN AIDS estimate, as well as the Ministry of Health, that there are about 158,000 people in Ukraine living with HIV. Talk about Ukraine specifically as the case study here, but estimates, I've also seen estimates up to 250,000, meaning there could be a large number of other people that haven't been diagnosed or have somehow fallen out of the healthcare system. And of course, there's been some disruption to that in occupied territories, obviously. Of these, 77% of the 158,000 number are on antiretroviral therapy, of which 51% are suppressed. So viral suppression, which is clinically what you achieve for treatment for HIV. There were almost 9,700 deaths by HIV were recorded in Ukraine in 2023. This is up in the first 9 months of 2023. 9,700 new infections, and 1,198 deaths. I have a few new statistics I added here in proof that HIV and tuberculosis together, that tuberculosis is listed as a cause of AIDS-related death in about 20% of cases, 20 to 30% of cases, 33% of cases in Ukraine of HIV deaths are caused by TB. It's estimated that of the HIV positive population in Ukraine, at least 20% are also co-infected or also are tuberculosis positive. Of those 50%, 56% of those TB positive, HIV positive people identified are have been treated or are under treatment for tuberculosis as well. There's a little bit more statistics in prisoners, sex workers, and men who have sex with men, which are at-risk populations in many countries. It's 5 to 7% prevalence. Injection drug users are not really recorded in these UNAIDS statistics from 2019 for Ukraine, but we do know there's a significant injection drug user HIV prevalence, as well as transmissions of other viruses like hepatitis C in that population from some studies. Okay, so the epidemiology of the HIV pandemic really relies on knowledge. We say there's a little campaign that goes around the United States called Knowledge is Power, and that's the key to understanding risk and community-based and individual-based prevention of transmission and exposure to the virus. The main routes of transmission are really injection drug use, contaminated blood products, heterosexual transmission, as well as homosexual transmission. Injection drug use is one of the highest reasons for HIV transmission, but regular sexual transmission is also very possible with this virus, and is one of the traditional modes of transmission, both in Africa and in the rest of the world. The high-risk groups, the highest risk groups are people who, injection drug users, commercial sex workers, men who have sex with men, pregnant women, because of the complications that can arise from HIV infection, and the possibility of transmitting perinatally onto during birthing, and then displaced people, prisoners, people living in congregate housing are also at risk. And all heterosexual and homosexual people who have unprotected sex are theoretically at some risk for contracting HIV, especially if it's with a partner who is HIV positive. There's I'll get to that in a second, but there's some prevention mechanisms for this now. So prevention, the key thing for injection drug users, which is a high-risk population, is avoid sharing contaminated needles. This is something that goes on in Ukraine, having clean needle programs, for example, for injection drug use. Screening blood products, practicing safe sex, community education, especially for women and girls, access to testing and care, the availability of rapid testing, like these oral rapid mouth testing, which do have to be confirmed in a laboratory test, but at least give some indication and have a relatively 50 to 90% accuracy rate in their positivity. Antiretroviral therapy is a great way of preventing HIV because it drives the viral load down to an untransmittable level, basically. And then in people who are discordant or people who are at risk, who are HIV negative, they can take antiretroviral drugs in advance. This is called pre-exposure prophylaxis, or PrEP. So this is for high-risk populations, particularly if you have a couple, for example, or a sex partner who is HIV positive and the other one is HIV negative, the HIV negative person would be recommended for PrEP. This is something, there's a bit of this in Ukraine. It's not as big a program as it is here in the United States and in some other places, but it does exist. Women's health is also very important in the HIV epidemic. In any setting, antiretroviral therapy or antiretroviral treatment for HIV-infected pregnant women, avoiding breastfeeding where practical if someone is HIV positive is important, and then education and empowerment for safe sex and for sexual choices is an important part of HIV prevention as well. And then finally, treatment. The current recommendation is to start HIV antiretroviral treatment as soon as possible, as soon as diagnosis is positive. It used to be that you'd wait to a certain CD4 positive T cell level. We'll get into that. But now the recommendation is if somebody's HIV positive, immediately put them on antiretroviral drugs. The exception is if they have tuberculosis, you have to take that into consideration because there's the possibility of immune reconstitution syndrome, depending on how far they are along in their HIV infection. Okay, so HIV, this is a little bit about the pathogenesis of HIV-1 and HIV-2 and infection and AIDS. HIV-2, I'm not going to talk a lot about it. It really only occurs in West Africa. Everything we see outside of West Africa is HIV-1, so HIV just commonly, right? The principal target cell for HIV infection is the CD4 positive helper T cell or helper T lymphocyte. HIV infects and kills CD4 positive helper T cells. This causes an immunodeficiency. The immunodeficiency is acquired through the infection, so it's called acquired immunodeficiency syndrome. HIV also establishes a latent reservoir. So even if you eliminate actively replicating virus, you have a reservoir of HIV that is hidden in CD4, some small population of CD4 positive T cells, as well as potentially other cells. And the therapy for HIV is antiretroviral drugs, as you know. And this is a scanning electron microscopy image of a CD4 positive T cell that's infected by HIV. All those little bubbles coming off of the cell are HIV. Each CD4 positive T cell that's infected by HIV becomes a virus factory and produces thousands of HIV particles. The viral load spikes very high, up into the 10 to the 9th or higher level in an HIV infection if you look in the blood. Okay, so this is the HIV life cycle in brief, the replication cycle. The HIV virion is coated with a surface glycoprotein called GP120. This is the major target for neutralizing antibodies for HIV. It also binds onto HIV receptors on the susceptible CD4 positive T cell. That's the CD4 receptor itself, as well as co-receptors, for example, CCR5. There's another one, CXCR4, but CCR5 is usually what you see. The virus gets into the cells, it enters, uncoats. The virus carries its genome in RNA, about 11,000 nucleotides of RNA. The RNA undergoes reverse transcriptase, so it carries an enzyme called reverse transcriptase. It reverse transcribes the RNA into a double-stranded DNA copy of the viral genome. The DNA translocates into the nucleus, finds a nice spot into the host cell DNA, cuts and pastes itself in. That's called integration. And you have now integrated HIV DNA genome in the in the nucleus of the cell. In the DNA, this is called a provirus. The HIV genes are then expressed off of this through a promoter. Yes, question. Promoter on the left end to produce HIV messenger RNA transcripts, so to make HIV proteins, as well as full-length HIV genomes. These things all gather at the plasma membrane of the cell, assemble, and release into new HIV particles. The HIV protease plays a role in the maturation process for this for the new infectious HIV particles that are released from the cell. Okay. All right. Let's look what happens in the blood of a patient, of a person who is exposed to HIV and the progression to AIDS. So the normal range, the normal number of CD4 positive T cells per microliter of blood is 800 to 1,200. When somebody's infected with HIV, these cells are rapidly killed off by replicating HIV virus, and you see a drastic and steep drop in the HIV, in the CD4 positive T cell count. And you can actually see it drop down to numbers like 600, like 500. It gets down pretty low. At the same time, if you measure there in the red, on the right y-axis is the number of HIV RNA copies per milliliter of plasma blood, milliliter of blood or milliliter of plasma. This is called the viral load. You see that it goes rapidly from a very low level to a very high spike. Okay, this entire process where HIV initially goes in, infects lots of CD4 positive T cells, and replicates to a very high level, killing off the T cells. It's a systemic infection. It is in lymphoid organs. So CD4 positive T cells, these lymphocytes are found where? In circulating blood. They're found in lymph. They're found in lymph nodes. They're found in the spleen. They're found in gut-associated lymphoid tissue or GALT. Systemically throughout the body, these types of cells are attacked by HIV. So HIV infection is basically a systemic infection once it gets going within the first couple of weeks of exposure. And the CD4 T cell count drops drastically. Now, the bone marrow will start producing new CD4 T cells. The body mounts But HIV will still persist at a low level of infection in CD4 T cells in the body. The immune cells, the CD4 positive T cell count, then reconstitutes to some extent and reaches basically a set point. Okay, and that immune set point is the kind of maximum number of CD4 positive T lymphocytes, helper T cells that that patient is ever going to have again. All right, and it's somewhere above 600, maybe it's 1,000. It's generally lower than the starting number of T cells. Okay, it never reaches maximum health again. But the patient basically seems to, in a good part, recover from HIV infection. That early stage of HIV infection has some other symptoms, which we'll just talk about in a second. But if you wait over a period of time, HIV infection isn't gone. It has a latent reservoir. It has a low level of infection. It flares up. The immune system defeats it. It mutates. It flares up because reverse transcriptase is a mutable enzyme, makes mistakes in this generation of DNA. So you have a wide mutation spectrum of HIV that can occur during the course of an infection in one patient. And the immune system will defeat it. It'll come back. The immune system will defeat it. This goes on for a period of, minimum 5, usually up to 10, 12 years, even 14 years. So it's a chronic infection. It's a low-level infection. Health effects start to take place. You start to see health effects from this, debilitating health effects going in 5, 6, 7, 8, 10 years into it. Okay, the CD4 T cell count gradually drops during this whole period. The HIV viral load rebounds. At some point, they cross each other, and you start to have this is called a clinical latency period. But once they cross and you have a low enough CD4 positive T cell count, generally dropping below 500, you start to see constitutional symptoms, opportunistic diseases, and then severe immunodeficiency leading to death. Okay. Okay, so let's look at some of the acute HIV infection. This is what you first see when somebody is infected with HIV. 50 to 90% of individuals have more than one of these symptoms within 2 weeks after infection. The patient is very highly infectious in this first 2 or 3 months of HIV exposure and infection because they are in this very acute phase of the infection. Fever, fatigue, sore throat, muscle joints and aches, night sweats, headaches, diarrhea, rash, systemic lymphadenopathy, where there's swelling of lymph nodes throughout the body. Why HIV is attacking CD4 positive helper T lymphocytes in lymph nodes throughout the body. There's also a very highly inflammatory response happening at this time. There's a massive loss of CD4 positive T cells, particularly in the gut-associated lymphoid tissue. Digestion is never the same in somebody who has HIV. Even on treatment, there can be problems with this because the GALT never completely reconstitutes. There's also establishment of the latent HIV provirus reservoir, okay? If we look at some of the diagnostic tests that you can use to detect HIV, it's really dependent on viremia, meaning HIV in the blood. You can detect the viral RNA. You can detect viral antigens, meaning viral proteins. And you can also detect antibody response to HIV virus. So you'll see viral RNA in the plasma, really hitting about 3 weeks after exposure and initial infection. That's the peak of it, and you'll see, but you'll be able to detect viral RNA in the plasma of somebody who's untreated for life, basically for their life. All right. You also see P24 antigen. It's the capsid protein of the virus. You'll see that 3 weeks into the virus infection, and in that acute and early start of the chronic phase, you'll be able to detect P24 antigen. That's what some of these rapid tests are based on. The HIV, you also detect HIV antibody 2, 3, 4 weeks after exposure. Really got to wait about a month. And you'll see antibody to GP120. There's an ELISA test for that. You can also see HIV DNA because the virus integrates into CD4 positive T lymphocytes. So it's in the helper T cells. You can find by PCR either the RNA viremia in the blood, or you can find by taking the cells and finding the viral DNA in PBMC. Okay, so these are some of the diagnostic mechanisms for finding somebody who is acutely infected with HIV. If you test somebody within 3 days after a presumed exposure, generally you don't find anything because the RNA is not high enough, the antibody's hasn't started yet, the antigen doesn't exist. So testing somebody within the first 3 to 7 days after an exposure event, or what they think is an exposure event, can often give something like a false negative. It's better to wait for 2 weeks, even 3 weeks, to see if you can detect HIV, okay, in the patient. All right, a little bit more about what the HIV opportunistic infections, what AIDS really, the symptoms of AIDS that really happen. The CD4 T cell count dropping below 500 means that there's a severe immunocompromise occurring. When that happens, the opportunistic infections, many other microbes, including tuberculosis, go crazy. So you get primary infections, reactivation of herpes virus, reactivation of latent tuberculosis. There are other conditions and lots of weird fungal infections and so on. There are a lot of weird conditions. There are a lot of other conditions, wasting syndrome, cancers, tumors associated with herpes viruses, and so on, that can occur in people who have advanced AIDS, meaning really CD4 T cell count below 200 over a period of a year or two. This is almost 100% fatal, 99.9% fatal, untreated. So HIV, prior to the antiretroviral therapy, was a death sentence, 99% fatality. There are some people that survived, but this is what was going to happen 10 to 14 years after exposure. Okay, so now we have therapy, though, so it's not quite as bad today as it looks. I'm just going to talk a tiny bit, a review, you can review this on your own as well, about immunology. Okay, so I know you probably had some immunology at some point, but there's kind of a little bit of like, what is immunocompromised? So how does an immune system work? So our immune system is divided into two kind of like arms, the innate immune system and the adaptive immune system. The innate is the epithelial barriers to microbes entering the body. It is innate, has a very rapid antimicrobial response, immune signaling, trafficking of cells to the site of an infection with release of interferons, chemokines, cytokines, immune signaling, as well as most bacterial, parasitic, and fungal infections. In the case of viruses, including HIV, you usually see a very strong interferon type 1 response, alpha and beta interferon, in infected cells, as well as in the tissue, as well as in the immune cells that are responding to this. These interferon signals are very important for antiviral response. If you do experiments in mice with most viruses and you knock out the interferon system artificially by making a transgenic mice, and you give it some virus, like some non-lethal virus, it kills the mouse, okay? Interferon super important to marshaling this antiviral response in the innate immune system. One of the key things that interferon drives, as well as the infection process drives, is the presentation of pathogen epitopes, pathogen antigen molecules from the pathogen by dendritic cells and macrophages to the adaptive immune system. So they take up pieces, they chop up the antigen, and they traffic to draining lymph nodes or regional lymph nodes through the lymphatics, as well as the circulatory system, but generally through the lymphatics. And these dendritic cells will then talk to B lymphocytes, T lymphocytes, to generate a specific adaptive immune response against the specific antigen that they're carrying. So if they're carrying a piece of HIV GP120 and GP41 and HIV proteins, these small 13, 10 to 20 amino acid epitopes chopped up from the virus, they will present that to B cells. They will present that to T cells, helper T lymphocytes, cytotoxic T lymphocytes. There's got to be a lot of very strong TH1 type, interferon type antiviral immune signaling, cytokines, to get this thing to happen. And in this environment, HIV produces tons of infection, lots of antiviral cytokines. The generation of adaptive immunity early on in HIV infection is very efficient, even with this loss of CD4 positive T cells. You see antibodies produced by B cells that are specific to the GP120 that can neutralize HIV. You see cytotoxic T lymphocytes that are educated by dendritic cells, helped by these helper T cells with all this interferon, other types of interferon like interferon gamma they're producing. Those cells will go out and destroy HIV-infected cells. They'll go out, the helper T cells as well will help marshal this entire immune response by helping with the presentation to B cells as well as cytokine signaling. So helper T cells are a key part of the adaptive immune response. And this is, along with the cytotoxic T cells and the B cells, this is how we get adaptive immunity. The other thing is these types of T cells and B cells will form memory. Once the infection is cleared, they will form memory, and you'll see memory of that antigen in these T cells in the lymph nodes and in the spleen. Okay. So the specific antigens educate the lymph nodes, and early on, this is called the T cells and B cells that get this education under this environment, right? They'll get a very strong positive growth signal. They'll go through clonal expansion. You'll get thousands, millions of copies of these T cells, B cells, and so on that can defeat this very specific infection. Once the infection is cleared, you get cytokines like IL-10 and Tregs that will come in, cause contraction, and then memory of the immune response. And this whole thing takes a period of weeks, really kicks in a week after exposure, really peaks 2 to 3 weeks after, and goes on for about a month. And this happens in every infection that we get. The MHC1 that dendritic cells will present is called HLA1 or also HLA. So MHC, major histocompatibility complexes, are also called human leukocyte antigens, HLA. You've heard of that a lot. So HLA1 epitopes from HIV will drive CD8 positive cytotoxic T lymphocyte response. HLA2 epitopes presented by dendritic cells will drive CD4 positive helper T cell response, as well as marshal or generate B cells, plasma cells, and antibody response. The antibodies that are produced in HIV and many other infections are very, very specific. There are multiple isotypes. First, you see IgM. It's the first large pentameric antibody that shows up. Then you see the most common high-titer antibody in the blood, IgG. There's actually 4 or 5 different types of IgG. And then you also see mucosal antibodies like IgA. Very specific cytokines generate this response. Like we said, interferons, interferon gamma, IL-2, IL-12, in antiviral responses, and antimicrobial responses like antimycobacterial Th1 response. You see a very important role for IL-12 and TNF-alpha and interferon gamma. Okay, so the adaptive immune response to HIV-1 and HIV-2 is this classic antiviral immune response. All right. And what happens in chronic in infection is the lack of CD4 T cells as long-term decline occurs, decline and death of CD4 positive T cells. This anti-HIV response, as well as the CD4 positive B cell response, CD8 positive response, right? Cytotoxic T cell response, adaptive immune response to all pathogens starts to become deficient. And when CD4 T cells drop low enough, then they're not helping B cells produce antibodies. They're not producing the right cytokines. You don't get enough of them that are specific to the infection agent. And opportunistic infections that normally would not cause a massive infection or kill the patient end up doing exactly that. And the immune response essentially fails. Okay, the list of opportunistic infections in HIV is almost like a gradient that you can see depending on what the CD4 positive T cell count is. Some of the first infections that you'll see, opportunistic infections, are fungal. For example, thrush. You'll see other things like oral hairy leukoplakia. Tuberculosis is one of the early bacterial infections that's very common in HIV patients, whether it's primary, but particularly reactivation tuberculosis as well. And then you'll see also things like pneumocystis carinii pneumonia, histoplasmosis, coccidomycosis, fungal infections you don't see usually in normal healthy adults. toxoplasma, so parasitic type infections, and then atypical herpes virus diseases like atypical herpes simplex, reactivation of herpes virus like cytomegalovirus disease, which is not really in reality in most healthy people very common, and then weird also when somebody's severely immunocompromised, lots of other things, cancer and so on, as well as pathogens like Mycobacterium avium. All right, so other types of mycobacteria that you rarely see in humans unless they're severely immunocompromised. Okay, and these opportunistic infections, not every patient will get every one of these, but if they have tuberculosis, there's a good chance, you know, they're going to see that. And then you're going to also see something like some fungal infections like thrush, or you might see one of these other ones, as well as herpes virus. Herpes viruses are very common in prevalence in all populations, and you see reactivation and herpes virus infections as well as other things. These opportunistic infections, as well as the other chronic conditions, can end up killing the patient who has HIV, okay, and progresses to AIDS. So the progression to AIDS is really driven by this lowered CD4 T cell count, as well as the opportunistic infections and chronic conditions that accompanied this immunodeficiency. There's a nice chart here, color-coded, so you can see what kind of infection kind of occurs with different CD4 T cell count levels. Tuberculosis, really when CD4 T cell count gets below 500, that's when you really see MTB infection, tuberculosis infection. One of the early infections that was recognized was called pneumocystis carinii pneumonia, or pneumocystis jirovecii pneumonia, PCP pneumonia. It's changed its name, but that's also, it's rare in healthy adults. It's basically you'll see both in the lungs, okay, and viral infections, as I mentioned, things like Kaposi's sarcoma, cytomegalovirus, herpes simplex, and then things like chronic ulcers, pneumonitis, esophagitis, bronchitis, things with herpes simplex that you normally don't see in a healthy patient. Treating somebody who has all of this, the best thing you can possibly do is reconstitute their immune system by getting rid of HIV with antiretroviral drugs, or at least driving it down into latency, all right? There's danger in doing that because you can get inflammatory syndromes that are associated with tuberculosis and everything else, this immune response that goes and then kills all of these opportunistic pathogens, causing massive inflammation in the process, right? But once somebody gets to a late stage of AIDS like this, people have even gotten down to under 100 CD4 T cell count and survived because they got antiretroviral treatment. All right, but it's going to be complicated medically. There are other chronic conditions and diseases that can happen with this, including tumors, invasive cervical cancer, Kaposi's sarcoma, okay, encephalopathy, or neuro-AIDS, which is a central nervous system dysfunction. It's AIDS-related. This can actually occur even in people who are on antiretroviral virus treatment for a long period of time, but not nearly as severe as somebody who is untreated, okay? Lymphoma, wasting syndrome, and due to HIV depletion of gut-associated lymphoid tissue and other problems. So since 70% of people are on antiretrovirals, you don't see these as much as you did in the past. But there are people out there who are living with HIV and don't know it. So they may not know it until something along this list develops, all right? And then you test them and you say, my God, this tuberculosis, you're also HIV positive. You know, that's also why you have a herpes, you know, some reactivated herpes virus infection or something like this, or fungal infections, pneumococcus, pneumocystis, cryptococcus, and so on. Okay, so let's talk about antiretroviral drugs for a bit. The therapy against HIV infection is antiretroviral drug therapy. It's combination therapy. You have to use at least 3 drugs. HIV will mutate itself out. It has a high enough mutation rate in any one patient that 1 drug, it always develops resistance. 2 drugs, it almost always develops resistance. You have to have 3 drugs so that, like, basically mathematically, the virus cannot find a variant, mutate a variant that is resistant against 3 drugs and still maintains viral fitness, high enough levels of infection to high enough levels of replication to continue the infection. All right, so 3 drugs is very effective against this. It was discovered in the late 90s by researchers in New York City. Dr. David Ho and others at Rockefeller were some of the first people to try it. Okay, the drugs target different stages in the virus life cycle. The reverse transcriptase process, where the RNA is reverse transcribed into DNA, is an enzyme. We don't have a natural reverse transcriptase in our bodies. It's a great drug target. You can target it, and you're probably not going to cause too much damage to our cells in the process, right? So 2 nucleoside-like reverse transcriptase inhibitors are recommended, plus a 3rd drug. The 3rd drug can be a non-nucleoside reverse transcriptase inhibitor, a protease inhibitor, or an integrase strand inhibitor, a fusion inhibitor, or a CCR5 antagonist. Generally, it's a protease inhibitor. Occasionally, it's an NNRTI or one of these other ones, okay? And there are, if somebody develops some toxicity to one of the drugs or more than one of the drugs on the regimen, you can change them if you have other drugs available. You can change the 3rd agent, or you can change one in the backbone and change the 3rd agent, and so on. It used to be a patient had to take 3 separate drugs daily. Now, most of the time, the drugs are combined into one pill that they can take daily. There's also the idea of implanted long exposure, long duration release, drug release. They only have to get it, put in once a month, once every 6 months. That's not really a mainline treatment. Right now, it's still pills. Okay. If the patient stops taking antiretroviral therapy, the HIV titer will come back up. It'll come out of the latent reservoir. Untreated, it will go on to develop AIDS, okay? Starts the whole thing all over again. Antiretrovirals have to be taken for life, as you probably well know, okay? These are the targets of antiretroviral drugs. Let's look at the replication process down in the lower left first. Nucleoside reverse transcriptase inhibitors, you want to put 2 of those in. AZT or zidovudine is one of them. My pronunciation of these are terrible, but emtricitabine, tenofovir, lamivudine, 2 of these is in most regimens. Non-nucleoside reverse transcriptase inhibitors, nevirapine and efavirenz. And then then you add, so you have 2 of the NRTIs plus either the non-nucleoside or an integrase inhibitor, like there's 3 of them there, raltegravir, whichever depends on what's available in your clinical setting, or a protease inhibitor like ritonavir is very popular, very common to be used in this. There are newer drugs like enfuviratide, which is a fusion inhibitor. It prevents entry and release of the virus particle. And then there is another drug that I'm not sure if it's available in Ukraine, but it's called Maraviroc. It actually blocks the virus CCR5 co-receptor interaction. Okay, so these are the drug classes that are effective against HIV. Okay, in PrEP, if somebody is taking HIV PrEP, so they're HIV negative, their partner or the potential people they're exposed to sexually through drugs or whatever it is, or HIV positive, they're taking prophylactic anti-HIV drugs. Generally, it's, at least in the United States, it's recommended 2, and those are both non-nucleoside, those are both nucleoside reverse transcriptase inhibitors, emtricitabine, tenofovir, or something like this. To prevent HIV infection. So you don't throw in the protease inhibitor and everything, but instead you throw in the RT inhibitors. Why? RT, reverse transcriptase, is an early step in drug treatment that you can target in somebody who's newly infected. And again, has to be done. This is the patient is put on these drugs as soon as possible. Again, considering tuberculosis, which we'll get to in a second. There have been recent reports in the media that if you aggressively treat somebody early after exposure with drugs with the top limits you can possibly give to infants, for example, a baby that was born from an HIV-infected mother in Mississippi in the United States a few years ago, and massive amounts of drugs, came out, gave a press report, and said, wow, we cured this kid, is not going to get HIV. Wait 3 or 4 weeks later, you see viremia in the blood. The reason is, remember this curve. If you test too early, you don't see this. Also, there's a latent reservoir. It's very hard to stop a high-level exposure of HIV with drugs after the exposure has occurred. Pre-exposure prophylaxis has the drugs there already, so it has a higher success rate in preventing HIV infection, all right? So even if somebody's exposed and they get HIV in them, it can potentially stop the replication process before you get establishment of a latent reservoir. Okay. When you put somebody on HIV drugs, especially in the case of they have tuberculosis, latent or reactivating tuberculosis, the immune system can reconstitute rather rapidly in the space of weeks. And now they have lots of CD4 positive T cells coming back to life. And, you know, the bone marrow produces more. You get CD4s, CD8s, B cells, antibodies, and you get new T cell memory to other infections that now this person who's reconstituted had been dealing with from opportunistic infections. One of those is tuberculosis. This also happens with other opportunistic infections, and the immune system will go after these infections like crazy. And it will do this in a very, very strong way. And when that happens, you can get a very inflammatory, destructive pathology associated with immune reconstitution and the immune system killing off these opportunistic pathogens. Okay, so when somebody has TB and they have progressive HIV infection, eventually their anti-tuberculosis immune response decreases because they don't have good CD4s, right? And tuberculosis mycobacterial, you know, CFU or burden starts to go up. The bacteria persists. You'll find it in the lungs. You'll get subclinical bacterial replication from the tuberculosis. When you come in and hit that situation hard and treat with antiretroviral drugs, suddenly you have the immune response responding very strongly to these bacteria. What do bacteria contain? Lots of factors, TDM and mycobacterial lipids on the surface of these tuberculosis bacteria. Those are all highly inflammatory substances. They are pathogen-associated molecular patterns. They will activate a very strong innate immune response, inflammatory response, high levels of TNF-alpha, IL-12, interferon gamma. You get this very massive immune response generated against tuberculosis. If you actually look in the lungs of patients who have this reconstitution, this is called IRIS, or immune reconstitution inflammatory syndrome. They actually get worsening lung function and worsening inflammatory disease during this period. So TB comes back, it's getting killed, but the inflammation caused by that massive immune response actually decreases lung function. They may get rehospitalized or need for rehospitalized. There was a study in South Africa that one of my students brought to me recently showing that some large percentage, 40 to 70% of people who had long-term HIV, then when they went on antiretroviral, they were TB positive, ended up back in the hospital with immune reconstitution syndrome. Now, it can be managed, it can be treated, and the patient can recover from this, although there can be some destructive inflammatory pathology to the lungs. What are the long-term consequences of this? I'm not quite sure. You see this in adults. Potentially, I think you can see it in children. You can ask one of your clinical experts about that. Okay. So IRIS, one of the things you see with IRIS, it's in 10 to 25% of patients who receive antiretroviral therapy. Here's just a summary in words of what I just said. You also see this with other irises in 30% of TB cases. You also see cytomegalovirus, hepatitis B virus, hepatitis C virus, cryptococcus. You can also see iris-like immune reconstitution inflammatory syndrome on treatment with antiretrovirals in other long-term infections. Chronic infections, HBV, HCV. We'll get to those in a couple weeks. Okay. You continue ART during this process. It's not recommended to stop treating the HIV in the patient. You have to do it. Use targeted antimicrobial therapy to kill the tuberculosis, steroids to maybe modulate some of this inflammatory syndromes. And again, you have to consult clinical guidelines and clinical experts to say exactly what and how much to put in. This is just something to be aware of as a complication of antiretroviral treatment. Okay. All right, one more complication of HIV/AIDS that I'll talk about is neuroAIDS. This is something that HIV infection and pathology in the central and nervous system wasn't first recognized. It was recognized 10, 20 years into the HIV pandemic. So really around the year 2000, people started like doing MRIs and saying, wow, we're seeing inflammation in the central nervous system. And HIV may penetrate the blood-brain barrier and infect microglia, which are macrophages, essentially, these innate immune type cells, but they're neurospecific in the central nervous system. The activated microglia, because they're exposed to a virus, they're innate immune cells. What do? Release lots of chemokines. This can attract neutrophils. Neutrophils are another innate immune cell. They come to this site of infection. In this case, the central nervous system, right? This is bad. It can release reactive oxygen species proteases. They degranulate. They start destroying tissue. They start killing virus, but they also start destroying tissue and causing inflammation, edema, and so on, and immune cell infiltration in the central nervous system. Microglia can also directly damage CNS tissues by releasing reactive oxygen species, proteases, and so on, and engulfing or destroying neural stem cells or neural repair cells in the process. So an overact, but kind of the pathology of this is not quite as well understood as a central, you know, as an encephalitis or something like this that you'll see associated with another vector-borne disease or something like this, okay? Or herpes simplex encephalitis is a little bit more clinically studied than this. But this is thought to be the mechanism of HIV infection and damage in or neuropathy in the central nervous system. Long-term untreated, at least in some patients, even people on antiretrovirals to some extent, especially if they've had treatment holidays, meaning they stopped taking it and then took it again later, you can have dementia, wasting syndrome. And this syndrome may be exacerbated by drug abuse, including methamphetamines, or at least that's been what's been found in some studies. Okay. So this is another complication of HIV infection. All right. We just have a couple slides left. One of the other interesting things about HIV is that, as I mentioned, 99% of people just sort of progress over a period of between 5 and 14 years to HIV/AIDS. In the Western world, in Europe, in Ukraine, you're seeing, 10 years, 12 years, 14 years that this progression to AIDS happens. There are rapid progressors, subtype D infections in Africa, where people 3 to 5 years after exposure will end up with AIDS. So rapid progression, rapid wasting disease, lots of complications. It's like a hypervariant of HIV. You also observe people who are long-term non-progressors. This is less than 0.5% of the population of people who are HIV positive. They have lower viral set points, meaning that the peak titer in the acute phase of virus infection is lower than it is in a lot of other people, a log lower, maybe 10-fold lower, something like this. You have a very strong cytotoxic T cell response. The CD4 positive, helper T cell dip never, and the set point is much higher than you see in the normal person. And they drive the virus into latency very efficiently. These long-term non-progressors will go for years with a positive HIV titer to some extent in the blood, and they never seem to develop AIDS. All right. There are genetic variants within the human population, within us, who are capable of defeating HIV. We've dealt with retroviruses in our past. If we look at our genome, it's full of endogenous retrovirus genomes. The hominids, humans, Homo sapiens, has dealt with HIV in the past. Although in this case, it would be a bottleneck. If everybody got HIV, 99.5% of people would die, okay, without treatment. So long-term non-progressors are an interesting population to study. You're not going to see a lot of them clinically, but how they've defeated HIV is one of the key things, is a subject of great study, because maybe it can tell us something about a long-term treatment or cure. So one of the ways to cure right there in the middle is to eliminate active infection of HIV, right? So if you drive the infection down, then you find that latent immune reservoir and you can destroy it, you can target neutralize it, you can eliminate, clear HIV from the patient forever. This has not been accomplished, okay? There are lots of experiments, a lot of work being done on this, but it hasn't, there's some trials, some small-scale trials in the US and in Europe about that, but it hasn't been accomplished. There's one person, 2 people who have been treated and cured of HIV. One of them was the Berlin patient. He had advanced leukemia. He was on he was on antiretroviral drugs. He was HIV positive. He was being treated for leukemia. He got a bone marrow transplant from somebody who had CCR5 negative. So remember, the co-receptor HIV needs to get in. Some people are natural genetic mutants that do not have functional CCR5. It has what's called delta 32 mutation. Found a homozygous delta 32 mutant donor that matched his bone marrow blood cell type. Not an easy task. He's reconstituted that bone marrow. His HIV titer went down to zero. Wasn't seen for years. He recently died, though, because he had a lot of other health complications, and he donated a lot of his time and samples and energy to trying to find an HIV cure. Okay, Timothy Brown was his name. And also the possibility there can be a vaccine. You can find broadly neutralizing antibodies in any patient that has HIV. You can find antibodies that neutralize HIV. HIV mutates in vivo, unfortunately, always escapes in vivo antibody response. Okay, so vaccines always have to deal with this highly mutable virus. All major vaccine trials at this point have failed. Okay, adenovirus vector vaccines, 1,000 sex workers in Thailand, all of them have failed when they come up. You can get good response in macaques. You can get good response in a small, what looks like in a small cohort of humans that test safety and efficacy. When you go into an actual phase 3 trial, you don't see efficacy against preventing HIV infection. So a vaccine is either tomorrow or another 100 years off. We really don't know. Cure strategies, antiretrovirals are right now the only real game in town as far as treatment and mitigation of HIV, as well as preventing infection. Okay, so in summary, HIV and HIV 1 and 2 are retroviruses that cause AIDS. They destroy CD4 positive helper T cells, leading to immunodeficiency, which is under 500 cells per millimeter of blood, millimeter cubed of blood, microliter of blood. Opportunistic infections and conditions occur. These can lead to an immunodeficiency. These can lead to death untreated. The treatment is combinations of antiretroviral drugs. Remember, 2 NRTIs plus one of the other drugs. Change regimens when the patient's not able to handle them anymore. The first and second line drugs exist, and you can always find a regimen that's tolerated if you have access to the drugs. The highest risk of transmission is in injection drug users, commercial sex workers, as well as heterosexual transmission and perinatal transmission. Prevention is really based on retrovirus, antiretroviral drugs, eliminating an infection, testing, knowledge of infection, as well as women's health, which is a very important aspect and a little bit understudied as far as HIV prevention. Okay, thank you for paying attention. If there's any questions, I'll stick around and be able to answer them. Maybe.
Thank you very much for your gorgeous lecture, I want to say. And my question is regarding the genetical aspects. In the previous slide, you said that maybe in future, they will able to how to say, reconstitute immune response. How to do that? Is this correct that 25% of population of Earth is resistant to HIV? Not people can't be infected.
Mm-hmm. Yeah, there's some. It's less than 0.5% are long-term non-progressors, and the reasons are actually different from. Some of them have natural CCR5 mutations, so they don't have the co-receptor. And you can live without CCR5. It was thought that like during the Black Plague in Northern European populations, it was selected against for some reason. It's probably involved in antiviral responses against viral encephalitides like West Nile. Okay, but getting West Nile is a small price to pay for being resistant to HIV in a lot of ways, right? So, but other long-term non-progressors, it's not clear why. They have normal CCR5. They have very high CD8 positive cytotoxic T cell responses against HIV. Maybe they have endogenous retroviruses that have kind of trained their immune system. We all have endogenous retroviruses. Their endogenous retrovirus response seems to be a little bit different, but it's not really clear in most cases why some people are long-term non-progressors. The idea of genetic therapy, though, is really keyed in right now on CCR5. So if you take an HIV patient and you take some stem cells from them that are HIV, there's no HIV in them, take some blood marrow, CD4 positive hematopoietic stem cells, go in and do some CRISPR, some genetic mutation or something like this, chop out the CCR5, grow them in good, clean laboratory conditions, right? Reconstitute their immune system with those CCR5 negative hematopoietic stem cells. They'll make CD4s that are CCR5 negative, and then they will have a population of CD4 cells that are resistant to HIV. All right. Now, HIV can switch co-receptors sometimes, especially in long-term infections, 5, 10, 12 years into it. You can find HIV change its from CCR5 to using a CXCR4 or even a couple other rarer co-receptors. So you got to be careful about that. And but mainly CCR5 is both the receptor for virus that's co-receptor for the virus that's transmissible and for a major part of killing off the CD4 positive T cells. So the genetic therapies are those ideas. Obviously, that's a $100,000 treatment. That's something you might be able to, it's under trials right now, but it's not necessarily something that can be democratized to the 39 million people who have HIV, the majority of them in less resourced countries. Unfortunately, the cure strategies might be a little bit better because maybe they can be based on some drug that's injectable over a period of time. You can find this latent reservoir and keep it suppressed or activate it temporarily and destroy it or something like this. So there's a lot of work on that as well.
Mm-hmm. Thank you very much for this understandable answer. And we have one question in the chat. Could you repeat, please, about the approach for pregnant women treatment with HIV and the way of prophylaxis of transmission to a child during the birth, which is dependent on viral load, and what to do with the breastfeeding? Thank you.
Yeah, and I'm not going to give a very detailed answer because I don't know all of the clinical recommendations for this. But in general, you treat pregnant women who have HIV with antiretrovirals, okay?
Yeah.
Got to be very careful about tolerance of the drug regimen. And by driving down their HIV, you prevent the perinatal or exposure and transmission to the child. That's the idea. Breastfeeding is not recommended for somebody who's HIV positive.
No.
Even if they're on the antiretrovirals, it's still, at least in the United States, not recommended to breastfeed in that case.
Yeah, I agree. I know that pregnant women have to be treated with antiretroviral treatment for sure to get the viral load close to zero. And immediately after the delivery, child should be checked for HIV. And after that, as I'm not mistaken, child should be prevented, treated. I'm not really sure how is that, but please, you can ask your teacher, an infectious disease teacher. I'm not infectious disease specialist, unfortunately, but I know that preventive treatment should be prescribed. Ольга Вікторовна, ви тут?
Yeah, and it's PrEP is actually recommended for postnatal transmission, so instead of giving like the full regimen of 3 drugs to the infant who's born, right, you can give them PrEP, which is these 2 NRTIs. Did you guys see the balloons? Every time I do this, there are balloons. I don't know, Zoom or something. But yeah, you can give PrEP to an infant that's born to an HIV infected mother. And there's recommendations exactly what the dosage and which drugs are recommended and tolerated for that particular purpose. But most PrEP, if you just pull PrEP off the shelf, it's for children or adolescents and adults. It's not for infants. So you have to check the guidelines very specifically for what PrEP is allowed for infants or just after birth.
Thank you very much. And I wanted to ask one more question about the syndrome of reconstitution of immune system. For instance, in Ukraine, if we see this syndrome, we include into the scheme of treatment corticosteroids because it helps us a lot. And we are doing a lot of solution and infusion intravenously. And sometimes it helps, but the majority of patients, unfortunately, are dying. Do you know how to help patients to fight with this syndrome? Maybe in the United States, you have some another recommendations about that.
Yeah, and that's actually a great question, and that's one we can direct towards our TB physician here in the United States, Dr. Tara Ness, or maybe Dr. Lange would be able to answer that in the case of what's recommended in Germany. But yeah, iris is potentially very dangerous, and the steroids are pretty much used, I think, in most countries as a way of lowering that level of inflammation. But the success of them and which ones are used, and is there some path that promotes long-term that promotes better survival? I'm not exactly sure the answer to that question, but I can look something up, or we can ask our clinicians about that.
Okay.
Lange, might you have some insight into that on the German side?
Mm-hmm. Thank you very much. So please, шановні колеги, якщо у вас є питання, задавайте, будь ласка. Можливість чудова.
Thank you for your great lecture, Eric. And I want to ask about HIV-2. You said that this strain is only in West Africa, as I understand correctly. Yeah. Mm-hmm. How do you think, according to the intense migration of the people from those territories, is the strain expected to found in Europe or any other countries in near future? And are there any difference in clinical course of HIV-2 or something like this?
Yeah, that's a great question. Yeah, HIV-2 has gone with people from West Africa from the beginning. So you do find HIV-2 cases outside of West Africa. It's just not epidemic outside of West Africa. But you do find cases of it outside of West Africa. People have traveled from there, or clusters of people and so on in some cases. I think it tends, at least from the studies that have been done, the progression to AIDS and the severity of it is less than HIV-1, but also it does eventually lead to immunocompromise and death. So it has to be treated pretty much the same way.
Hmm.
But like broad answer, there's probably very specific guidelines if you see a case of HIV-2, but without guidelines, just treat it like HIV-1. But in West Africa, it's more epidemic in certain countries.
Okay, thank you. And another question about treatment. You talked about we should take two drugs, the nucleoside reverse transferases, yeah, and one of the three another drugs. But why we do not use the three different drugs to acting in more possible actions of
yeah, and the answer is in the literature. There have been like every possible drug combination tried for HIV and published in small studies. Okay, so like 2 NRTIs plus 2 of the third agents, or 1 NRTI plus 2 different of the third agents. And drug companies, companies that make these drugs are also very interested in what's going to be the best, treatment. There is a question of tolerance as well. Some drugs have higher sort of toxicity, like AZT, especially at high levels, is higher toxicity than some of the other NRTIs. So that's part of it. The idea is you can put it all in one pill. So which three drugs does that company have a license to put into that pill is also part of the equation at this point. So you look at that pill and is it effective against Truvada, for example, against, you know, the standard of care. So the answer in an ideal world, you would have every possibility, but in the reality, the clinical recommendations are based on the best knowledge that's available for.
Thank you. Thank you.
So thank you very much. I think if our colleagues will have some questions, they can ask us. Вельмишановні колеги, якщо у вас є питання, залишаються, будь ласка. Ось тут у нас на екрані доктор Борtz демонструє імейл. Ви можете побачити його імейл. Також в нашій об'яві ви можете знайти веб-сайт. Доктор Борtz запрошує вас ознайомитися з його роботою. Якщо ви бажаєте співпрацювати в будь-якому сенсі, будь ласка, звертайтеся до нас. Можемо організувати щось цікаве. Thank you very much. I hope that the majority of people joined. Unfortunately, I already said that we have some problems with electricity and with the internet connection because of missile attack, everyday bombing, unfortunately. Yeah, and not all people will be able to join, unfortunately, but we will share your slides, of course. Thank you very much. And I hope to see you again.
See you.
Yeah.
See you.
Thank you.
Nice to meet you.
Bye bye.
Bye, everyone.
Thank you.
Bye bye.
Thank you very much.
Yeah.
Thank you.